So, welcome to the Transplantation podcast. Today, I have Dr. Demetrios Morris here with me to talk about very interesting work in transplant surgery and how we can sustain the transplant surgery workforce at this critical juncture in our field. So, welcome to the podcast. Thanks for joining me today.
Thanks for inviting me.
Yeah. So, to start off, can you tell me what motivated your team to write this commentary and why do you see this as such a pivotal moment for transplant surgery and the workforce?
So let me give you some background. I'm originally from Greece. I did my residency at Duke University, and I'm a second year fellow at Georgetown. I'm joining the faculty next year. So after that, cycle of training in different systems, different continents, I was thinking where the field is moving and how the future of transplantation will shape the next few years and what is the role we have as emerging surgeons, and some of us have the ambition to become leaders. So I invited some senior surgeons from different institutions, different careers, some of them division chiefs, some of them like rising stars in transplantation, and I shared these thoughts, and they were really interested in pushing and publishing that piece. And because right now with machine perfusion and the way that the profession is evolving, there are many things that require some attention and some improvement. So my overall experience and how I see the future were the main trigger why we decided to write that piece.
Very cool. So early in your paper, you make the point that workforce sustainability is about much more than surgeon well-being, right? So how does this issue in your mind connect to organ utilization and public trust in transplantation?
Yeah, so the paper is not like about burnout and wellness, or not only about them. Is first of all, and I'm pretty sure you have a similar experience, like talking to trainees and people who have the ambition to be involved in transplantation. I see many talented people who, as med students or residents, they have interest in doing transplant, and because of the the difficulties they are expected to encounter, not only about work hours, but about reimbursement, about recognition of their work, about the sustainability of the phenotype of a surgeon scientist or a surgeon educator, they decide to go towards pathways that are maybe partially overlapping with transplant, like some go to surgical oncology, some go to MIS, because they think that the experience they will have and the quality of life will be better. And the truth is that transplant field is not easy, but it's not about the wellness. Like now with machine perfusion, many transplants, the majority at least here at Georgetown, happen during daytime, and it's not only about the wellness, and it's about patient care. You can provide better patient care having more available resources, but also is about science. Like now you can evaluate organs in a different dimension, more mechanistic idea about ischemia, reperfusion, injury, viability criteria. So it's a field that is booming, but I feel that is not as attractive as it used to be. Like my perception, and this is why one of the reasons we wrote that piece is that there is still a critical mass of people who are like ambitious enough and romantic enough and resilient enough that they want to be involved in transplantation. But the way that the field is evolving, um, more aggressive organ utilization, more marginal donors, more marginal recipients, we need highly skilled and talented people to join the field. And we have to find ways not to make it more attractive, but to make it sustainable. It's not about like maintaining the technical excellence, is maintaining the sustainability of the field. And that was the reason we wrote the paper, like a call of action for people who make decisions on that, how to attract more talent and keep the field alive and prosperous for the future.
So you described clinical unpredictability as one of the biggest deterrents for people entering the field of transplantation. Can you tell me from your experience, what does that unpredictability look like in a day-to-day transplant practice? And why is that such a challenge for recruitment?
Yeah. So obviously, you come in the hospital and you have a significant amount of elective cases, like in a busy program like Georgetown. But then, multiple donors, very complex donors, pediatric donors, intestinal donors. Like this is, the destiny of these type of programs that are, the pure all-time multi-organ programs, and that adds a lot of unpredictability. And you still, we are a large program, we have many fellows, but we have all these patients who have needs for complex operation, complex decisions, and you know there are many days that you have to work and go to multiple recoveries and do complex cases, because that's the patient population we serve. So definitely it's not as, knowing that you will go and you will have a clinic to see 10 patients, or like you will have your totally elective cases and you will go home. So for some people that's very interesting, and this is what actually makes them to follow the field of transplantation. But for some other people it's kind of unstable factor. I think with machine perfusion, we have more options to make it less unpredictable. But it's part of the nature of our field, the unpredictability, and it's part of the charm. So the main position of the paper is not like we have to eliminate the unpredictability. We have to embrace it, but the idea is how to make it more sustainable and utilize resources in a way that um, that thing will become a central for the future capacity, equity, and credibility of the program. And if you achieve that, or if you work towards that direction, all involved parties, physicians, patients, and public trust will be aligned, because they will realize that there is an organized way how to make it sustainable, how you will get the best possible care at any moment. And this is what the paper is talking about.
Yeah, so to me, some of the more optimistic points in your commentary really were about the role of machine perfusion and how we can sort of advances in organ preservation can make transplant surgery more predictable. But you also highlight the problem of the traditional 24-hour call structures and so the inadequate recovery time that transplant surgeons have that can contribute to this fatigue and burnout. How serious of a problem is this right now across transplant surgery from your perspective?
Yeah, I mean, obviously each program, they have their own ways of like um adjusting to that reality. Like, the clear roles of donor surgeon, recipient surgeon, and how these responsibilities are divided, and utilization of OPO, donor surgeons utilizing machine perfusion. So the same team that might go for a recovery will not be the same team that will have to implant the organ. For kidneys, it's even easier. It's easier, to sip organs without having to deploy a team and go and recover that. So I think it's not only about the 24-hour and how you will logistically work around it, because there are many ways. Like, if you have a week that you have a very busy recipient time, then maybe your next week will be an academic growth week and you will have time for physical recovery, and also to focus on, and this is what this opinion piece is highlighting, how we can keep that phenotype that we inherited from prior generations of the surgeon scientist, or like the transplant surgeon educator. So I think there are ways to work around that. It's not as bad as it sounds. And that's why I think the main point of the paper wasn't to talk about burnout. It was like how to shape the future of transplantation to make it more attractive. Like, we are inheriting a field from giants. Like, I had the pleasure to work with like surgeon scientists at Duke, like Dr. Alan Kirk, Dr. Stuart Tineckley, Dr. Deb Shedan. And here at Georgetown, people who have like played the critical role in establishing multivisceral intestinal transplantation, like Dr. Fishbein, Dr. Matsumoto, Dr. Genik. So all these people survived that culture of that time. But now the volume is going up. A transplant surgeon is required to do multiple things, to know machine perfusion, to know multi-organ transplantation, to know hepatobiliary and pancreatic surgery. So there should be, and also to become active in the community, present in ASTS, present in science. So in order to achieve that with rising volume of 10% in almost every program in the country, there should be a way without like changing, the nature of our field to be more efficient and utilize the personnel in a way that they remain committed to excellence, but also they will not burn out or they will not like struggle to provide appropriate care.
So, one of the things that you note in the article is that there's this declining interest in transplant surgery among the general surgery residents. Um, what's driving that trend?
Yeah, so I think and I'm not sure what is your experience from all these years that you have been interacting with trainees and students. Everybody is amazed by the nature of the operations and the technicality, but then they realize that the quality of life during the 2 years of fellowship is very challenging because of the work hours, because of the hours that you need to be awake, because of the complexity of patient care. I think we are not, approaching and advertising the, the qualities of our training the right way. And there are some people who are prioritizing other things in life. There is a component of like resilience and ambition and being romantic uh, to be able to decide that I want to do transplant. There is a part of personal sacrifice. The families behind of I see it from my own family. They have to be willing to pay the price that you will be absent for many hours. But the reward you are getting, and when you see patients who come with very high melds or desperate, in a death pathway, and then they get the second chance in life, that's something that not many fields can give that to you. And philosophically, transplant is a very positive field. It's all about life. It's not about how to prevent death. So I think if we highlight the technical aspect, the scientific aspect, this how we serve the community, and I think more and more people will be attracted to that, and they will be willing to, you know, not prioritize the extent of work hours and everything. But the problem is that people sometimes stay superficially and they see the sacrifice we have to make, and they are discouraged to do that. So I think having a better strategy, highlighting the advantages of undergoing that training for 2 years, and that another thing is how these people are like transplant surgeons are getting reversed down the road, and some people say, oh, I will have to suffer for 2 years, I will have to do that um, advanced training, but then my training and my personal sacrifices will not be recognized by the healthcare system. So that's another reason why people are getting discouraged from doing transplant training. So I feel that the community has to pay some attention on all these things, and if we want to really reverse that trend and hire more and more talent to make our system sustainable, and both in terms of like volume of people involved, but also like for talent available, then some of these things have to change.
Yeah, that makes a lot of sense. Let's talk a little bit more about the fellowship training aspect. So you call for a couple of really interesting ideas. One is competency-based fellowship training with explicit milestones. And the other is that there's this vulnerable transition from fellowship to independent practice. And so you're talking about this structured early career launch period. So can you talk to me about those? Like, what does this look like for you? What is the competency-based fellowship training with the explicit milestones and then that early career launch period look like?
Yeah. So the idea behind that is like not novel, but it has to do with like, the fellowship is a 2 year fellowship. Um, and we should have an appropriate structure how people are achieving independence and autonomy, and what are, the technical milestones they have to meet. And obviously, the programs are not standardized doing that. There are programs like our program that is a typical multi-organ HB program, but there are other programs that are providing only kidney or kidney liver training. But how, like, the first year, what is the timeline that you should become independent in deceased donor recoveries? What is the timeline that you should become independent doing straightforward kidney transplant? And then that's usually a first year endeavor. And then during the second year, like, to become progressively more advanced doing like straightforward liver transplant, multivisceral transplants, redo transplant, HPB, pancreas transplant. So I think, many programs are starting incorporating what is done already in general surgery with like seeking for immediate feedback from the attendings, setting like splitting the cases in different zones and say, today I will work on, the hepatectomy part of liver transplantation. The next time I will be doing the sewing. The next time I will be focusing on the artery and the bile duct. And I think in this way, not only you are progressing all fellows equally, but you are also getting more fellows involved in every case. So, there are, tasks for the second year fellow, there are tasks for the first year fellow. Everybody feels included, everybody gets early exposure to the whole spectrum of transplantation. So more people are feeling satisfied with their training, and they are more likely to advocate for their training and bring more talented people in the field. So I think that's the overall idea of doing that. And then the transition from being a fellow to being an attending is very critical. Like the mentorship you will have clear goals. What is your career goals and how you can build on them? Like, it's different to be a pure clinician. It's different to be a surgeon scientist. It's different to be a surgeon educator. How your schedule will be structured, the opportunities you will have for funding, the opportunities you will have to be extrovert and present your programs to the program to the community. These things have to start from the fellowship time, but also, you have in the first couple of years after, graduating, and this is the phase I'm right now, they're pretty critical how you will evolve in the field. So with that opinion piece, we are trying to bring the attention to that part as well. Like that transition is not easy, but has to be targeted. It's not like one size fits all. Like every graduate has their own needs and their own strengths, and the program should be aware of that, how they will work towards generating future leaders in transplantation.
So the commentary also suggests that once you get done with fellowship, that the academic promotion pathways don't really reflect the actual nature and reality of transplant practice. What do you see as the biggest mismatch between the transplant surgeons and what institutions reward for promotion?
Yeah, so obviously, transplant centers prioritize volume and complexity, but if we see it like in an isolated way, I'm really worried that the field of the surgeon scientist within transplantation, and transplantation seems to be a very appropriate field to generate surgeon scientists, will vanish. So the idea is, not every graduate has the same passion and the same talent to publish or do basic science, but they might really strong in, community service or like outreach or like being present in ASTS and help with policy making or be great educators. So that's why I think every program should approach every fellow they hire as a possible future faculty in their program or like out in the community, and utilize and hone their strengths so they can be really, useful to the community. Right now it's not about expanding the donor pool and expanding the clinical volume, but it's also an effort to expand the pool of people who are willing to dedicate their careers to that goal. And in order to make it more attractive and, more beneficial for our community, for our patients, and for the individual surgeons, we have to individualize how we approach that. So you cannot have universal strict criteria how to promote the resources you will be able to allocate for every individual, because the priorities and strengths and talents each individual has are different. So I feel that's the point, that it has to be individualized. It's not one size fits all. It's everybody will have individual sacrifices, but it requires an intelligent organizational design how to best benefit the future surgeons and make them successful.
So you proposed three domains for defining academic productivity in transplant surgery, right? So clinical excellence, applied scholarship, and systems leadership. Um, can you talk me through all of these? What do these mean in your mind?
So clinical excellence is straightforward. Um, Transplantation is a heavy technical and clinical field. So you have to be as excellent as possible and competent technically, be able to adjust to the new reality of like, robotic surgery, provide bedside patient care in very complex patients and families that, they come to you when patients are really sick and sometimes you are the last hope they have. Academic productivity and scholar activity, for those who are committed and passionate about the surgeon scientist, the extroversion of your program, the extroversion of your work, being able to publish, being able to present your work, and be able to attract different opinions, like multi-institutional collaborations, and keep growing the field from scientific standpoint is critical. Transplantation is about patient care, but patient care will improve if you bring the mechanistic background why some patients are doing well, why some patients require different allocation of resources, what is the right organ for the right patient. All these things are dependent on the clinical experience, but also there is a lot of basic science, translational research, multi-institutional collaboration that can shed some light to all these unanswered questions of the field. And then the last one is, you know, see how to change the system and being involved in the administration. Um, Transplant is a highly regulated field, and probably you have witnessed all this hard work that our current leaders are doing regarding access to living donation and all these things that will give birth or allow multiple smaller fields within transplantation to blossom, like transplant oncology, which is heavily dependent on the availability of living donors or expanding the deceased donor pool and utilize ex, you know marginal organs that you can optimize on a pump and use them for patients who have cancer and they can actually benefit from a transplant. So I feel the triple thread doctrine that we grew with the years of our medical school and the years of residency is very applicable to transplantation, like excellent surgeons, excellent scientists, and excellent leaders. And in order to make it sustainable, you need to try to attract the best possible people in the field. And I think that's the role of the current leadership, but also the future leaders to make it possible.
Excellent, excellent. That makes a lot of sense. The paper also references this measurable attrition among these early career transplant surgeons. What do we know about why people are leaving and what are the consequences to the field?
Yeah, so I think there are some um, papers. Some of them are recent, some of them are 5 years ago, published in prestigious transplant journals, and it was like mainly surveys to early career surgeons, and they were highlighting risk factors for early attrition, and these have to do, with the burnout, the quality of the daily practice, but also has to do with reimbursement. For example, it will be interesting to see updated data from ASTS regarding the reimbursement of transplant surgeons and how this can be compared to other fields that are not necessarily similar, but we have overlapping patient populations. And the last data we have are from 2022, and since 2022, many things have happened to the world and they have affected the economy and everything. So I feel that plays also a role. But deep inside, I think philosophically, transplant surgeons want to feel that their hard work, their dedication to patient care, their dedication to promoting the field is getting recognized and rewarded in multiple aspects. And when this is not coming, you can see many people in early career steps that they have not committed like 10 years as an attending to a program or to like a field. They might go to something that is more rewarding or less, intense. And the issue is like the training they got during transplant has already given them the skill set to have that flexibility. So we are losing talent, and still, I think we have the critical mass available to keep the field moving forward. But the way that the volume is increasing, the way that the complexity of cases is increasing, I think there needs to be a generous policy how to attract more people and make it sustainable in long term. Because right now, I think that we have a balance of the folks who are, retiring and the new entries in the field, but that balance might easily change, and the actual volume that every program is doing and the complexity is going up, and more people are needed.
Yeah, especially because you're addressing things like public scrutiny around organ procurement practices and allocation fairness and some of these external pressures that transplant surgeons are facing every day. I'm sure that's really impacting the stability of our workforce. Um, you also talk about the term moral injury in your paper. For our listeners who may be less familiar with the topic moral injury, what does that mean?
Yeah, so you know, transplantation is a very sensitive field because it has to do with the donor and their families, and also the recipient, the need, the high acuity patients, the high mortality on the waiting list. So, also it depends on the individual background. There are still people who are questioning the criteria of brain death. Also, the whole thing with the DCDs and some negative, you know, backlash we had recently is like, there are many concerns about the field from the general population, and there is like lack of trust. That's why I think if we have standardized ways how we train our people. We have standardized ways how the programs are working, and not only at regulatory level, but also like the actual level of daily practice. Strive for excellence, clinical excellence, technical excellence, generate leaders who are like not only leaders in technicality, but opinion leaders and thoughtful people. Um, I think that will create an environment that people will feel trusted, and that moral injury that might be happening because of some questionable decisions at some levels, or the overall impression that the general public has, will be totally reversed. Because when people see how we actually work and the small miracles that happen every day to these patients, they will definitely approach things in a different way. So I feel that we, as a field, we have to become more extrovert. We have to be present wherever is needed, at the political level, at the community level, at the scientific level, and all these injuries and levels of mistrust will subside as long as we have a commitment how we will move the field forward, and how our future leaders will emerge and save the field. So I'm really optimistic about that. I'm not discouraged at all, but it's a challenge that we are facing at different levels, even the level of a trainee that I am right now. And that needs to be addressed in a multi-factorial way, not only at the political level, not only as at the communication level, but also we shouldn't stay passive, and we have to show the good things we do and how we benefit the community with our work.
I love that. Your paper also points to international examples, right? Including structured procurement roles and national call systems. As organ procurement in the United States is rapidly evolving, to say it quietly, what lessons do you think that the US transplant community can take from any international models?
Yeah, I mean, the biggest thing is access to living donation. And we have seen that in the kidney field there is, the numbers are stagnant. despite recent changes, NKR, etc. And for the liver, because of the stakes of that operation and the people are concerned regarding the possible complications, etc., there is a lot of pressure for good outcomes. But there are other healthcare systems. I'm not saying that we need to emulate how they perform, but the access to living donation, the way that the living donation is discussed with the patients, and is totally different, and they are totally based on living donations. So I feel that's one structure that our community has recognized as a potential, solution to increase the donor pool, but also like provide access to care, transplant care to more recipients that are having low MELs, but they are hospitalized pretty frequently with complications, or they have a tumor that can be potentially cured with transplantation, but they don't have that access. So I feel we have to be more extrovert. There are many things that we should be proud of, but there are many areas for improvement. And I feel the current leadership in the community is working hard towards that direction to make the transplantation a field, a scientific and a surgical field that people can understand in lay words, and they can see the obvious benefits for advocating for that, and that will affect the referral systems, the local hepatologists or the local GI doctors or the local internal medicine doctors will have lower threshold to refer patients to for a transplant evaluation, even if transplant will not be a priority, because access to care will be easier and people can understand the benefits from proceeding with transplantation. So um, I feel these examples from abroad can be easily used. It's not always, the U.S. healthcare system is different than many European or like Asian healthcare systems, but the main theme is the same. We are here for patient care. So I feel that, taking advantage of these examples and optimizing, facilitating care to living donation will be critical for the next years.
No, I love that. I donated a kidney 17 years ago to my cousin when I was in law school. And my biggest concern I've had about living donation, and I've worked on this in countless research studies and countless advocacy things. And I've even served as our vice president of patient donor affairs for the OPTN. I've worked on this in countless ways. And you're right, living donation still has not been able to really evolve. One of the things that I really do wish that we did have was long-term follow-up care for our living donors. I feel like maybe other countries do that better, and maybe if we did that better here, we could get more people in care because there are real risks to these things, and if we don't take care of donors afterwards, it just feels kind of like, why are we going halfway and not all the way? So I think maybe there's a difference in our healthcare system and the way we take care of people in general, and living donors just happen to sit in that. I think healthcare is more of a right in other countries than it is in the United States for populations, and I don't know, that's just my 2 cents on the living donation. I agree with you. um, okay, so one of the other things that I wanted to mention was you have three big priorities moving forward. You want to redesign clinical operations, modernize training, and realign these promotion metrics. I think they're probably all urgent and we probably need to do them all at once, right? But if you had to pick one thing that we could focus on right now that the transplant programs listening to this could implement right away, what would be the most practical reform that you think someone could implement today?
I think the fellowship, this is where the future of transplantation will be born. And not like the fellowship as, the 2 years of training, but the preparation of um, surgical residents who want to enter the transplant field. I think, this is where you will attract uh, talent and more people to come and join an effort to modernize the way that the system is working, modernize clinical practice. We need fresh ideas. We need like people who get modern training in transplantation that transitioning to a robotic transplantation setting will be easier for them because they have the background training during the years of residency to like keep moving forward with the surgeon scientist phenotype. That phenotype cannot be born the 2 years of fellowship or as an early attending. You need to have that passion. You need to have that dedication early on, and you need the leaders should be able to track these people if this is what they feel is required for the field, to track them early, identify the talent, and try to maximize the potential. So I think if we had to do only one of them, is making the fellowship and the field more attractive to talent. We cannot be always saying that people who cannot stay in transplantation are weak. People who cannot stay in transplantation, they were not committed enough. There are many people with the right approach can join that journey and they can push the field forward. So we need people who are ambitious enough, idealistic enough, resilient enough, but also, it's not only about the personal sacrifice, it's about having a system that is recognizing hard work, reimburses people in various ways, but mainly, creating an environment of success. And I think the programs that do that, they are more likely to become prominent or remain prominent the next few decades because they will be generating people who will be very qualified, but they will be willing to attract more talent. They will not be afraid of the accumulation of talent, and that will push the field forward. So if I had to pick one of the three as a absolute priority, I would say is reforming the fellowship, which is the mitra of the field. This is where the future leaders are born, and that would have been my priority.
I love it. Ambitious, idealistic, and resilient, right? Did I get that right? All three characteristics that we need in our
Yeah.
transplant surgeons. I love it. So, my last question to you is to end on a positive note for our trainees and early career surgeons that might be listening. What gives you hope about the future of transplant surgery despite all of these challenges?
Well, I was like when I was in my training and I was thinking about what should I do and how I will approach it and everything. I was talking to various people and they were telling me if someone like you with your goals, your pedigree, and the privilege you had to work with these leaders, inspirational people that I mentioned before, you don't have enough motivation to go to transplant, then there is a problem. So I feel I think we still have a critical mass of thoughtful leaders, um, very, impressive surgeons, great surgeon scientists who can like pass, the torch to the next generation of surgeons and create an environment that, future generation of transplant surgeons will grow and will become successful. Each one of us have their own goals in life, and transplant comes with uh, personal sacrifices, and you have to be prepared for that. But I feel the field is booming. We are in a phase that the field has never seen before. It's not about designing novel operations. It's not about finding new immunosuppressive meds. It's about expanding the field to more disease processes, oncology, minimally invasive living donation, xenotransplant. So I feel that the field is booming and it will be a failure of mine, let me put it this way, if I'm not part of that journey. So the way I approach it is that, that field is booming. Many innovations are coming. It's the model that has existed, generated, and created pioneers from technical and scientific aspect. But you know, we need more workforce. We need people who have the talent and the commitment to join that journey because it's the future of medicine and surgery. If you see the other fields are talking about less surgery, less invasive surgery, more oncology, more medicine. The field of transplantation is the one that, despite the fact that it's 75 years old, it keeps evolving to more radical operation, more advanced science, more, disease processes to be treated with transplantation. So I feel, it's a very impressive field that is evolving. Um, the feedback you get from patients and the rewards, it's hard to find in any other field. And I think that palliates kind of the concern that the personal sacrifice is critical. If the field evolves and reforms, it will not be about, it will not be a model that will be based on personal sacrifice, but it will be a model based on, you know, the incredible achievements, the accumulation of talent, and the innovation. So I'm really hopeful about the future.
I love it. Thank you so much, Dr. Morris, for chatting with me about transplant surgery and our workforce and how we can grow it and sustain it and make our young transplant surgeons academically successful as well as system leaders. I think this is an incredibly important topic, and I hope you can talk more about it in more rooms and places and spaces. I think it's really important. So, thank you for joining me on the Transplantation Podcast. Papers available online right now. You can find it. Transplant Surgery, Sustaining a Workforce at a Critical Juncture by Morris et al. Thank you again for your time. I really appreciate you chatting with me.
Thank you so much for the opportunity. Thank you.